Good morning. I'm Dr. Bernard Bendock from the Mayo Clinic in Arizona. I'm a neurosurgeon.
My name is Sujay Vora. I'm a radiation oncologist here at Mayo Clinic, Arizona.
We're both honored to be here with you today on this Facebook Live at the Precision Neurotherapeutics Lab here at Mayo Clinic. This laboratory is focused on using simulation science and 3D printing to study brain tumors and skull-based tumors and to design better treatments for those diseases. We're talking to you today about brain tumors and skull-based tumors. This is a disease that Dr. Sujay Vora are talking about and working on a daily basis. Dr. Sujay Vora is going to talk to you a little bit about primary brain tumors and metastatic tumors, and then I'll speak to you a little bit about meningiomas and skull-based tumors.
Primary brain tumors are tumors such as gliomas that originate actually in the brain tissue themselves, and they're considered malignant. Metastatic disease, or secondary tumors to the brain, are cancers that spread from other parts of the body. For example, lung cancer has a very high chance of ultimately spreading into the brain tissue. Radiation oncologists, neurosurgeons, neuro-oncologists, neuroradiologists, we're all part of a team that work together to appropriately manage these patients and work together to provide our patients the best care. You had some, in terms of how we diagnose patients, one of the things that we do is we always talk to our patients about being very close with their doctors in terms of reporting any problems that they may have. Brain tumors can present in many different ways. For example, some parts of the brain, if a tumor is present, it can cause a seizure. In other parts of the brain, it could cause some weakness. The important part that we wanted to relay is that it's important for you to let your doctors know what you're feeling and experiencing. If you are having symptoms such as these, many times we'll do an MRI, and that's usually our first test in trying to see what's going on. And based on the imaging qualities and the characteristics of that MRI, we appropriately will have patients see Dr. Bendock and his team to first figure out the best way of managing the problem.
You know, we're fortunate, Sujay, as you know, to be here at Mayo Clinic where we're surrounded by a fantastic team. We work on a daily basis with our neuro-oncologists from the Department of Neurology, your colleagues in radiation oncology who are world-class experts, my colleagues in neurosurgery, fantastic radiologists, endocrinology when there are endocrine issues, ophthalmology when tumors are near the optic nerves, and so on and so forth. And the team actually is larger than even that. And so we actually work as a team, and all our brain tumors patients and skull-based tumor patients see essentially almost the entire team. Sometimes we alter the itinerary based on where the tumor is. For example, if a tumor is near the hearing nerve, we'll make sure that they hear our world-class hearing experts, audiologists and neuro-otologists, and so on and so forth. So it is individualized, but the important concept is that we work as a team. We meet weekly at our neuro-oncology conference, and between phone calls and emails and so on, we're probably meeting online 3 or 4 times a day in various ways to either discuss difficult scenarios, come up with good treatment plans, and design treatment plans, or bring some data to the simulation lab here where we can either print the pathology or do a computer simulation that allows us to deliver a more accurate plan. And I know that you have a lot of experience with that on the radiation side in terms of sometimes the question comes up, should we use radiation with gamma knife or radiosurgery, or should we use proton beam? And I've been amazed at how you can simulate those treatments and actually do the treatment on a computer so that we can get a sense of what the result may be with this approach or that approach, and then come back to the patient with a more precise plan. I was going to mention just a couple words about skull-based tumors and meningiomas. So Dr. Vora talked to you a little bit about primary brain tumors, tumors that arise from the brain tissue itself, and metastatic tumors, tumors that come from elsewhere in the body. Those tumors have different treatment approaches. I'll talk a little bit about meningiomas. Meningiomas are tumors that arise from the lining of the brain and spinal cord. So they can occur anywhere where the lining is touching the brain. So they can occur on top of the brain, underneath the brain, where we refer to them as skull-based tumors because it's at the base of the skull, and essentially anywhere in the spinal canal. The important thing about these tumors is that they're often benign, most often benign, but they can compress important structures. So a tumor that may be small elsewhere in the body may be quote-unquote massive when it's sitting underneath the brain because it may be pushing on a very important nerve that can control the way your eye moves, the way your hearing nerve works, the way your swallowing apparatus works, and so on and so forth. So these tumors become very important because they can affect quality of life based on where they're located. And when we talk about skull-based tumors, we also are talking about pituitary tumors and acoustic neuromas and other tumors of the skull base. Metastatic tumors can also invade the skull base. Head and neck tumors can also encroach on the skull base, and we're fortunate to work with a world-class ENT department that has pioneered many great approaches to work through the nose and through the neck to get us exposure and good treatment options for these types of tumors. When it comes to diagnosis, I'll just briefly mention that it always starts with a good history. So the headache quality. Headaches are very common, but headaches that are worse, for example, with lying down may imply a higher pressure. And brain tumors can increase the pressure in the head. That's to be distinguished from a migraine headache. So we work closely with our neurologists who are experts at headache and so on to distinguish between what we call a benign headache and a headache that could imply a more serious condition in the brain or spinal cord. MRI has become very, very important. MRI, and there's a lot of innovation going on that front in terms of being able to interrogate the tumor as to what's going on with it, even metabolically. And so we rely on MRI really with our, beyond the history and physical exam, to be a very important tool in the diagnosis. Sometimes spinal fluid is needed for certain types of tumors. Tumors that grow around the pineal region often require spinal fluid check to help us with the differential diagnosis, and sometimes even the treatment. Sometimes we use the spinal fluid pathway to treat certain tumors such as lymphoma, which we collaborate on as well. So on that point, I thought maybe we'd transition Dr. Vora to talking a little bit about just summarizing the treatment options again, and then we're going to talk to you a little bit today about the innovations that we've seen in our respective fields, me in neurosurgery and Dr. Vora on the radiation oncology front. And one message I have for everyone today is that to not think about these treatments as sort of independent, siloed in different parts of the hospital. In fact, Dr. Vora and I work down the hall from each other strategically because we often think about ways to integrate our treatments and to make sure that my treatment is working well with your treatment, and sometimes we use combinational therapy. So on that note, could you advance the slide? We'll have our colleague advance the slide for us.
Yeah, so as far as the treatment options, so once a tumor is found, generally by imaging, as Dr. Bendock mentioned, I think of cancer care as being a team sport. We really rely on all of our colleagues to work together to figure out what the best way to appropriately manage the patient. So these are the different tools that we have available. We have surgery, we have radiation, we have different types of chemotherapy, we have biologic therapy, we have immunotherapies, we have other techniques such as embolization to stop blood flow to some of these types of tumors. And then many of these tumors do actually require a combination. So again, it's the integration of care that really helps to provide our patients, first of all, good information to kind of understand what's happening to them and why we want to treat them a certain way. And you know, a place like Mayo Clinic, we do offer the ability to integrate these treatment options seamlessly in order to get patients treated very quickly. What we're going to do next is kind of talk about some of the new innovations that are available. We'll first start with neurosurgery.
So one of the things I'm really excited about when we talk about innovations is the kind of things we're doing here in the Precision Neurotherapeutics Lab. This is a patient who had a tumor involving the skull base, and we were actually able to print the tumor. You see the tumor here in blue, and working with colleagues at Mayo Rochester and Mayo Clinic, Florida, designed a treatment plan that took into account the optic nerve that we were able to see in this model. And this actually allowed us to deliver a better treatment based on the fact that we were able to understand the treatment. We were actually also able to have the patient better understand their disease by holding the model, and that gave the patient a certain sense of ownership over the problem and allowed them to be a partner in the treatment plan, which we always aim for. In terms of neurosurgery and the neurosurgery side, historically we thought of neurosurgery as basically craniotomy, and neurosurgery has really evolved in many ways to augment the traditional craniotomy, and I'll talk a little bit about that. So one of the treatments I'm very excited to talk about today is laser ablation. So laser ablation allows us through a very tiny incision to make a small opening in the skull, advance a catheter into a tumor. This is not appropriate for every tumor, but for certain tumors this could be a great treatment for tumors that are inaccessible or that cannot be treated safely with other ways, we can actually put the catheter into the tumor and deliver heat therapy in the MRI scanner. So we can actually watch the therapy being delivered in the MR scanner to deliver heat therapy into the tumor and kill the tumor cells. And this is what it looks like. Catheter is advanced. This is a cartoon, obviously, a simplified cartoon, but a catheter is advanced into the tumor. And then under MR guidance, we're able to deliver heat therapy, much like Dr. Vora can deliver radiation therapy. The current trend is all about precision therapy, basically matching the right treatment to the right patient and being able to deliver it to the tumor with as little collateral damage as possible. The goal is to treat the tumor but not affect the surrounding brain to the greatest degree possible. So as we think about that concept, so with primary brain tumors, one of our goals is to remove as many bad tumor cells as possible but not affect function, because we have to remember the two big goals. One is longevity. We want people to live long and good lives. And the second, and equally important, maybe sometimes even more important, is the quality of life. It doesn't make sense to remove every bit of tumor if doing that will result in a major neurological deficit. So that's something we very much care about. And one of the advances that has occurred and that we continue to work on is the concept of awake brain surgery. With awake brain surgery, we're able to test neurological function during the operation. So if we're trying to make a decision about whether to resect one last piece of brain tissue that is involved with tumor, we can test that tissue by stimulating it with a device to see if that piece of the brain, that part of the brain, is important to function. We've actually had some patients bring in their musical instruments to make sure that they can still perform, because it's no longer enough to make sure that somebody's talking and walking. We have to make sure that they're happy with their abilities after surgery. So that's a very important part of the equation. This is just a video of that. And here you see a patient playing the piano, a keyboard in this case, to make sure that the tumor that involved her musical center, as we operated on it, that we were able to preserve that function. That was a very important goal of surgery. We can't monitor that at all if the patient is fully asleep. I should mention that the patient is typically sedated for the opening, so they don't remember much. And then we wake them up just for that part where we need to test their function and operate on the more critical parts of the brain that could be affected by the operation. Dr. Vora is going to talk to you next about radiation therapy, and so many exciting advances have occurred on that front, including the proton beam. But I'll mention 2 points. One is, it used to be in the old days, you had to find a fantastic doctor, and I think that's still very true. But I think the name of the game in 2017 and beyond is to find a great team. And one of the things we take great pride in here at Mayo Clinic, and this goes way back to the Mayo brothers, is this concept of working in teams to deliver great care, because modern care, no one person can do it alone. It does require assembling a very cohesive, collaborative team. And along those lines, not only do we need to assemble the people who are involved in the care, but also to think about how to assemble the treatment tools and options. So we didn't talk a lot about that today, but there are some tumors that could benefit from embolization, like meningiomas and skull-based tumors. So oftentimes, Dr. Vora and I and our neuro-oncology colleagues will design a treatment plan that includes embolization, surgery, and proton beam, and that's really where I think a lot of exciting things are occurring. So on that note, Dr. Vora, maybe you can talk to us a little about radiation therapy and proton beam therapy.
Okay, well, thank you. Radiation is basically not a new tool that we've used for patients with cancer. It's actually been around since the late 1800s. But over the last decade, I would say, there's been significant advances in the use of radiation. Radiation is basically an X-ray treatment that we point kind of like a flashlight. And the idea is to kill the tumor with treatments either done at one time or done over several days to several weeks. Again, we tailor the treatment based on the type of cancer it is, the location of it, whether or not they've had surgery or other procedures prior to treatment, whether or not we need to add chemotherapy into the mix. So again, as we've, a common theme here is that we have to really work together to design the optimal treatment. But radiation has been around for a long time. There has been some significant advances in radiation therapy. The first is, first of all, we can actually see these tumors much better than what we could do in the past. And the advances in medical imaging, whether it be with MRI, PET scans, or a combination, really allows us to visualize what we need to treat and what we need to protect. And then in terms of radiation delivery, there's a lot of options now. So a couple of the options that I'll comment on, one is stereotactic radiosurgery. If you Google that into a computer, you're going to see words like gamma knife, cyberknife, Novalis. There's a several companies that provide the technology, but the important part is to have the team of physicians and physicists and other medical personnel that can make sure that what we can do is something that we can actually deliver and deliver safely for all of our patients. Proton beam therapy is probably the most recent change that we've had within our department, and it's been a significant change. And I just wanted to show a couple of examples of how things have changed over time. With traditional radiation, if you ever had an X-ray for a chest X-ray or dental films, the radiation actually goes through and through the body. So as you can see in this example, while the radiation is treating that whitish tumor in the middle, there's radiation exposure in front of the tumor and radiation exposure behind the tumor. We can manipulate that with a lot of advances in traditional radiation by coming in from lots of different angles, kind of using the tumor as a fulcrum. And by doing that, we get the maximum dose again in the tumor, but there's still low doses of radiation that's given to large parts of the brain. Proton beam is a different type of radiation treatment where it's almost like a depth charge where we dial up the energy, it goes into the tumor, it drops its radiation energy, and then there's very little radiation exposure after that. So in this example, this shows the differences between a proton beam, which is in yellow, and a standard X-ray, and the extra or excess radiation that's caused by the treatment. With protons, as I mentioned, we're just literally dropping the radiation right into the tumor, and there's relatively low doses of radiation to the tissues around it. And we've now tried to take that technology to the next level. We offer a technology called pencil beam scanning proton beam therapy, where you can almost imagine a paintbrush. We're literally painting the radiation right over the tumor. And again, maximizing the dose where it needs to go and minimizing the dose to all the healthy brain tissue. Because quality of life is just as important as treating your tumor, and all of our treatments are really trying to balance the two. This is an example of what I used to do for a child with a pediatric malignancy called Medulloblastoma. The entire spinal axis is considered a risk, so we'd have to treat all of the brain tissue and the entire spine. And because of the older technologies, a lot of radiation was given to a lot of the anterior structures, such as the heart, the lungs, and many of these kids that we used to treat 10, 15 years later would actually have more problems related to their treatment than they did from their original cancer. But with proton beams, we can actually get the radiation to stop. So as you can see in this example, the radiation is actually literally stopping just in front of the spine and protecting all of the anterior structures, the heart, the lungs, and these kids have a much lower chance of developing problems or complications related to their their radiation treatment. We just wanted to also, before we answer any questions, is leave you with a few resources. We can only go over so much during the short period of time, but there's a wealth of information that's available on the internet, almost too much information. But the National Cancer Institute have a couple good websites, cancer.gov and cancer.gov/clinical trials, where a lot of basic information about brain tumors are present, but also innovative therapies that are being looked at nationally and trying to fight these types of problems. And finally, mayoclinic.org does provide a lot of good information as well, and we encourage the audience to take a look.
Thank you, Dr. Mora.
All right, so we're now turning to questions from Facebook. Our first question is there any type of research that an undergraduate student should pursue in this particular field? Any recommendations for students?
Well, what I would say is that we actually have a number of undergraduate students in our laboratory, and email us and we'll see if we'll talk to you about the opportunities at our lab. But I would encourage you to encourage any undergraduate to work, if they care about cancer research, to connect at their university with cancer researchers. And certainly here at Mayo Clinic we have very active research in cancer, and we'd be happy to connect on a more one-on-one basis on that front.
All right, the second question comes from Kim. How dangerous is a pineal cyst? And on a similar note, Kim also asks, how dangerous is a pituitary tumor?
Okay, obviously those are both can be either treated as simple questions or very complex questions. I'll start with the pineal cyst. So pineal cysts, first of all, the most important thing is to make sure that it is indeed a pineal cyst and not something else. So it's very important that the imaging be of high quality and make that determination. The second thing I'll say is that many pineal cysts, when they're small and not causing a lot of compression, can be observed. So many of them actually do not need intervention or surgery. Some do, and I have operated on several in my career, and sometimes they do need surgery, but the most important thing is to get consultation with a neurologist and or a neurosurgeon before undergoing treatment for a pineal cyst. Regarding pituitary tumors, obviously how dangerous a pituitary tumor can be depends on a number of factors, and it would take quite a while to talk about all those factors, but I'll just briefly mention that what a pituitary tumor is doing from either a hormonal standpoint or a pressure standpoint are what determines how dangerous the tumor can be. On the pressure side, probably the most important issue is to what degree the pituitary tumor is compressing the optic nerves, the visual nerves. That is the danger that can come from a pituitary tumor. That's probably the most important area to discuss. On the hormonal side, it is there are some hormonal imbalances that a pituitary tumor can cause that can be quite dangerous. So it's very important to work with a medical doctor, an endocrinologist, and a pituitary team to make sure that these issues are checked and treated and under control.
All right, we have a question from Linda. Have you ever done embolization of brain tumor as a standalone treatment for tumors near foramen jugular nerves and sinus sigmoids?
Okay, so the question is about embolization. So there are embolization, most often embolization is an adjunct tool to other tools that we use for tumors, most of the time. There are some rare scenarios where embolization alone can be used for certain tumors. I won't go into examples here because that would take a little bit too much time, but certainly I would seek consultation. We'd be happy to provide more one-on-one input on that through a consultation at Mayo Clinic. But there are some scenarios where embolization can be very effective on its own, but more often than not, embolization is used as a tool to prepare for surgery or as an adjunct tool to other modalities.
All right, we have a question from Cheryl. What about IMRT as it compares to proton beam?
So IMRT is probably the most advanced form of traditional radiation that uses photons. And what we can create now with IMRT plans are quite elegant, and we can do a very good job at healthy tissue sparing with IMRT. So it is a very commonly used modality for treatment of these types of problems. Proton beam is similar in many ways, but it has a different type of radiation path. So as I showed in that example, the radiation actually stops. It's actually deposited in the tumor, and there's less radiation exposure to the tissues nearby. So if you compare plants, and we do that many times in our department to really prove to ourselves that it really does seem that protons offers a real advantage compared to IMRT, we'll actually run the plans both ways using IMRT and proton beam and really try to provide the patient the best treatment.
We have a question from Penny. Can meningiomas be treated with radiation?
Potentially, yes. It really depends on a few different factors. It's a little complicated to answer it completely, but it really depends on the tumor location. Is it actually compressing and causing pressure, causing symptoms? Because radiation does not tend to cause these tumors to shrink. It's really working with our surgical colleagues and trying to decide, yes, this tumor is quite large, it's causing enough pressure and problems where it really should come out first before considering any radiation. But there are some patients, very elderly patients, for example, where there appears to be a meningioma that's growing very slowly over time that we decide to treat before it causes symptoms. So we do get involved at times. But again, I think it is a bit of a team approach in trying to decide which patient should get which treatment.
And I think two of the biggest advances on that question over the last decade that I've seen are, one, the fact that the way we approach a lot of skull-based tumors compared to the 1980s is that we go in trying to create a better radiosurgery or radiation target. In other words, in the 10, 20 years ago, we used to be much more aggressive about trying to get every last bit of cell out. Now we try to get as many cells out as we can, but at the same time trying to minimize risk to the cranial nerves and other brain structures. So in other words, we can actually take away that part of the tumor that would be high risk for radiation, leaving for radiation what radiation does best, and that is treat, for example, a tumor that is pressing on the brainstem, but also invading the cavernous sinus. I just saw a patient like that yesterday. And you could actually draw on the MRI what you should remove surgically to make proton beam and radiosurgery safer. So that combinational therapy, I think, is where the greatest advances are occurring. And I think it's allowed us to be safer, get patients home faster and back to their normal life faster by having that combinational approach.
Hi Jessica, thanks for tuning in. We have a question. Do you have neurosurgeons at Mayo who are experienced in operating on a pilocytic astrocytoma in an adult in the brainstem spinal cord area? Would this type of tumor benefit from proton beam therapy?
So there's two parts to that question. Obviously, we can't answer any question about an individual case because we'd have to study the nuances and the imaging and so on. But as a general statement, pilocytic astrocytomas can be occasionally cured with surgery. So we look at every case very carefully to see, can we resect every last cell of that tumor, because we can often get very good results in many patients. That being said, there are times when there are anatomic issues or structural issues in the brain that would prohibit a complete resection. And so what are your thoughts on proton beam for pilocytic astrocytoma?
I think it's a modality that we could consider for sure. And again, some of the inherent advantages of proton beam can be used in this situation. But it is a complicated question to answer without reviewing all the nuances of the case.
Right. I think the key is to look at updated imaging. And oftentimes we need to look at all the old imaging from the first diagnosis, post-treatment, and more recent imaging. And that's the kind of thing we do on a daily basis. It's hard to answer that kind of question without having studied the entire story and the entire of both the clinical course and the imaging course and what was done, either surgically or through other modalities.
All right, we have just time for a few more questions. Amy asked, do you watch and wait for someone with a total resection of oligodendroglioma, grade 2, or do you start treatment? She's a 36-year-old female, and I know we can't answer specifically, but what would your recommendation be for somebody who's wondering, when do I start treatment?
So that, again, on this Facebook Live, it's very hard to give individual patient advice, and we would love to review the specifics of the case. One of the things we take into consideration with all our brain tumors now is the genetic profiling, and that can often guide those challenging questions as to whether we should add to surgery, chemotherapy, and radiation. And we run a brain tumor conference on a weekly basis, and we would be delighted to review cases that are sent to us through the mayoclinic.org or through an appointment process. So I'm sorry we can't give a more specific answer, but it is a very good question. And I would advise seeking several opinions by a brain tumor team to answer that question more precisely.
Thank you. And our final question comes from Albert. What are some of the risks of using proton beam?
Well, like any other type of radiation treatment, it's a combination of trying to get enough radiation in to cure or stop the tumor from growing versus potentially causing side effects. So a lot of what we do is try to basically balance those two parts of the equation. For some tumors that are very close to the brainstem, for example, proton sometimes does offer some advantages in being able to get the radiation in safely. But if there is a lot of compression or if the patient's having a lot of symptoms related to it, sometimes it's not very easy to just reverse. So again, I think it would require sort of a team approach in looking at the images. We need a neuroradiologist, we use a neuropathologist, we use a lot of other parts of the team to really give the patient the right advice in terms of what the best management tool would be.
Dr. Vora, Dr. Bendock, thank you so much for joining us for the Mayo Clinic Neuro Chat. If people are interested in learning more, where can they visit us online?
We advise going to mayoclinic.org, and our Mayo Clinic teams are on standby to help with questions.
Great, thank you so much.